Hello and welcome to this Orthohub Fireside chat, coming to you live from Birmingham. It could have been worse. We could have been in Coventry. I don't have my trusty sidekick slash dancing monkey, Pete Bates, here. I feel slightly naked. But even better than that, I've got two of the biggest names in the world of knee surgery here, and I'm really hoping that some of their knowledge, skill, talent, and money will rub off on me. But I'm already feeling smarter just sitting here, just bathing in their auras. So normally, when we record these in the studio, we have a clacker that goes to let us know it started. So would you mind just smacking your hands together just once, then we can start? Thank you. That's all the applause you're going to get. And we're off. So listen, I've been given total carte blanche by Conmed to talk about anything that we like. We've not been asked to discuss any implants, anything from Conmed. There's no sales here. It's slightly unusual. I was like, are you sure? I mean, you're sponsoring the session. They said no. So they've got a stand here. It's up to you if you want to go and visit them. They're clearly not bothered. I'm joking, but it does mean we can talk openly, and I'm grateful to them for that. So the title of this fireside chat is What the Experts Really Do, Proven Tactics for a Smooth Practice and Avoiding Pitfalls. So the key focus here is none of this on the podium bollocks, real questions, honest answers for everyday practices. So we're joined by two esteemed guests here. I've Peter Verdonk, an orthopaedic surgeon at the Antwerp Orthopaedic Center and professor at the University of Antwerp, or Antwerpen, as we linguists like to say. And he's also a visiting surgeon at Aspetar in Qatar. And we have Al Getgood, an orthopaedic surgeon at the Fowler Kennedy Sport Medicine Center, assistant professor at the University of Western Ontario, also a visiting surgeon in Abu Dhabi and Aspetar in Qatar. I've just realized I'm the only one here who's not working in the Middle East. I'm really missing a trick here, aren't I? I need to get over to Saudi ASAP. These chaps got suitcases full of Rolexes. Just go down to the cloakroom, the one you can't lift. So listen, it's a huge shame that Tim can't be here. He deserves all the congratulations. This is his meeting. It's in its 20th year, and he's been such a driving force. He was supposed to be here with us right now, as you can see. So if you could just have a round of applause and thanks for Timothy John Wallace Spalding. And we'll pour out some liquor. But, you know, the main reason that I actually wanted to speak to Tim was I wanted to clear up one thing. And I'm really glad he's not here, because I really wanted to know why I wasn't shortlisted for his fellowship in 2013. I mean, I didn't even get an interview. It was cold. I mean, I'm kind of over it now. Yeah, I barely think about it. You know, the therapies really help.
I'm pretty sure the last time we spoke, Kash, actually you mentioned this. Just saying.
I did. The irony is that Tim and I now work closely together at Cleveland Clinic London, and I tell him regularly how he crushed my soul. Al, how many talks have you given at this meeting?
6, I believe.
6. They've really made you sing for your supper.
Well, yeah, it's an expensive flight, so I guess you got to get your money's worth, right?
That they have. Listen, you've shown some amazing cases. You are speaking at every single meeting I've ever been to, and the ones I don't go to, you're still there on the faculty. You work in Canada, Abu Dhabi, and Qatar. So the number one question that everyone wants to know here is, when do you actually do any bloody work to collect these cases?
Yeah, tell us.
Yeah, someone else does all the work, and I just do all the travel. No, I mean, I'm busy when I'm home. And, you know, we have an interesting sort of setup in Canada whereby I have a certain amount of OR time over the course of a year.
Yeah.
And so when I go away, I swap my OR time with one of my partners. So then when I'm home, then I'm working much harder when I'm there. And over the course of that year, I'll still do the same number of operations. But if I didn't travel, I'd probably be quite a quiet practice. And I don't want to do that in my mid to late 40s.
So Constantine is your practice?
Yeah.
Cool. And just out of interest, I actually wasn't going to ask this, but I'm curious. What's it like operating in the Middle East, working there? Peter, how do you find it?
I think for me, it's always foot on the ground. I mean, getting back to the reality of treating patients. Yeah. I mean, they're the same patients with the same issues.
Same pathologies?
They have different morphologies, different laxities, and you find out stuff. Yep. Things you never considered before, you suddenly discover like, okay. And one of the things that I learned in all humbleness was not to do Western medicine for Middle East patients. I mean, there's different things out there, and most likely, or maybe, they need a different treatment.
What do you mean by that exactly? I'm intrigued.
For example, my former boss, Professor Martens, was in the Middle East way before everybody else. And he was routinely doing LET on his patients.
Right.
And back then we were thinking that LET might be overdoing it. I'm talking 80s, 90s.
Yeah.
And so he was successful because he was routinely doing this on these patients because they really need it.
Right. So that's interesting. So is that where you got the idea, Al?
From the Middle East, no. I mean, I obviously wasn't in the Middle East at the time when I started instability, but I totally agree with Pete. You know, it's made, for me, I feel it's made me a better doctor, a better surgeon. You know, you're given challenges that you wouldn't ordinarily come across in your normal practice, and so I think by being out there, it's helped my patients when I then go back home to Ontario. So it's been a phenomenal experience, and we have, you know, we do what we call the Abu Dhabi Special, which is a combined anterior closing wedge osteotomy, BTB ACL revision with an LET. And that's pretty much all I do when I go out there.
And a Rolex.
And a Rolex, yeah. two.
One for each arm. No, that's impressive. And it's interesting you mentioned that because the fact is, so I do private practice here in London, and I would say that the private practice that I do has genuinely made the care I give my NHS patients better. Because you're seeing more patients, more morphologies, more testing types. And so it's very true, isn't it, that what you get in one place will benefit the other. Al, you talked yesterday about some pretty crazy cases. Femoral and tibial derotation osteotomies. You talked about LETs. You talked about these slope-correcting osteotomies. Do you ever just do a simple meniscectomy?
No,
They're not allowed in Canada.
that doesn't happen. What, you resect menisci? Nah, I mean, you know, at the end of the day, the reality is that a lot of, you know, Peter mentioned it on the podium as well today. You know, the reality is that a lot of patients, you cannot, you know, I can't plan what my patient comes into the office with. And so if they have a meniscus tear that I can't repair, you know, I do a resection.
Yeah.
And for me, it's just all about, you know, using some of his data that he's produced to be able to, you know, counsel patients appropriately and preempt the issues that they may face later down the track. And I think the worst thing, as I say to my residents and fellows, would be, you know, don't take out a meniscus that is repairable. That's, you know, that's kind of criminal. But you know, but if you have to resect a meniscus, you got to do it.
You know, the thing that blew my mind, actually, I've always told patients your risk of arthritis goes up the minute you tear your meniscus, and then when you've had a meniscectomy. But Andy Metcalf's slide that said it's 40 times higher chance of knee replacement. I had no idea it was that high. Pete, what do you tell people?
Well, first of all, I think we need to stop blaming meniscectomy as being the thing. It starts with the lesion.
Yeah.
And that's very important. I mean, we've been blaming the surgeon quite the last 10 years, and you're the driver of the disease, and you basically do stuff wrong. But it starts with the lesion. Yeah. And so from there, you have this cascade of getting into the OA. And it can start really early. I mean, we see patients 25, 28 come in with degenerative medial meniscus.
No, and the beauty of this meeting now is that not only do I not blame the surgeon, I'm also going to blame the patient's bone size. So thank you for that. Yeah, well, it's your parents' fault.
Yeah, it is your parents' fault, yeah.
In terms of meniscus repairs, so there's been a lot of quite high-value, really quite earnest conversation. It's been very useful. But for a lot of people, most people here will do the basics regularly. We'll see torn ACLs and torn menisci. What percentage are you doing all inside meniscus repairs versus inside out?
I think the all insides have dropped a little bit over the years, and the inside outs have gained. It's a little bit more complicated. You need people. We were discussing the setup of your clinic. I work in a public hospital, but it's run like a private hospital. So, and still I have enough people around me that can help me.
Yeah.
We were in 2 rooms all the time, 2 nurses all the time. They know what we do. We have fellows. Everybody's there, and they know what I'm supposed to do.
Yeah. Similar for you, Al?
Yeah, I mean, the vast majority are going to be all inside, because the majority of meniscus tears that I repair are at the time of ACL reconstruction. They're usually small longitudinal tears, and you know, the numbers of bucket handles that I'm seeing, is a small proportion of the meniscus repairs that I do. But the ones that really need the repair, yeah, I'm doing a lot of inside outs. And you know, it's kind of funny. I did a meniscus transplant in Abu Dhabi with Charlie, and we have a nurse there called Robert, Filipino nurse, fantastic. He's absolutely expert at catching needles, tying the sutures as we go, and he's used to doing it, and so we have that routine.
Yeah.
Robert's on holiday one week, I'm doing a meniscus transplant, so I get Charlie to catch the needles.
Yeah.
Hated every minute of it. Right? You know, and the reality, you know, when you're not down there and you're underneath the knee trying to catch these needles, it's tough. So you need expertise, you need people, and you need a team to be able to do that in an efficient manner.
And the thing that's interesting is, so I mentioned earlier, I'm now working with Tim Spalding. After kind of 8 years as a consultant, we now do a combined operating list once a fortnight at Cleveland. And so ironically, I'm now doing a fellowship kind of 8 years in. And so all the stuff that Kira was talking about was all familiar. And since we started doing meniscus transplants quite regularly, my number of inside-out repairs has gone up. And I just see a lot of meniscus tears, and I felt I was pretty competent at repairing them all inside. But I would encourage everyone here to try the inside out, particularly for some of the bucket handle tears. It's very handy just to reduce it, isn't it? Hold it in place and then fix around. But it's one of those things, if you don't practice it or do it regularly enough, when you really need to do it, you can be caught with your pants down.
Just on the note of the fellowship, Tim did say that you're an above average fellow, so it's okay.
As long as he signs my forms, it'll be all right. Do you guys, how are you enhancing your repairs biologically?
Basically marrow venting. That's the thing I do.
Microfracture the notch.
Microfracturing the notch. That's the only thing I do on a routine basis.
Yeah. And sorry, the technique for that, this might sound a bit simple, but are you coming in front of the ACL? Are you crossing portals, coming in front of the PCL?
I come in front of the ACL.
Okay.
That's where and a big hammer and a couple of big holes.
Fine. And you, Al?
Same, plus rasping. You gotta remember, when we do meniscus transplants, I put a dead bit of tissue into the knee, and I very rarely see a meniscus transplant that has issues healing peripherally.
Yeah.
They all heal. The problems I have with meniscus transplants are posterior root. So, you know, I think the vascularity is there to heal. It's really just the lesion that's the problem.
Fine. And what are your rehab protocols post-meniscus repair? Let's just say it's postural meniscus, you put in 2 all-inside meniscus repairs. How are you rehabbing them?
If they're isolated, they're going to be 3 weeks on crutches and 6 weeks, not beyond 90. If they're in association with an ACL, I try to reduce complexity and I'll just let them go. Unless I believe my jaw was technically not perfect, and then I would be a little bit more protected. But for my ACLs, I'll let them do the classic ACL rehab protocol.
Fully weight bear?
Fully weight bear and protected with a brace for 4 to 6 weeks.
How about you, Al?
Yeah, 95% of my repairs are at the same time as doing a cruciate, so the cruciate dictates rehab, but I probably reduce deep loaded squats past 90 degrees up until 3 months.
Yeah. The thing that's interesting about the meniscus repair is the literature quotes a re-tear rate of 20-odd%. Yet, I think a lot of people here, knee surgeons do that. It's nowhere near that. You can think of a handful of cases possibly that you've seen in the last 5-10 years. What do you counsel patients about the re-tear rate? Do you give them a number? Do you warn them? What do you say?
Well, I'll tell them based on the lesion specifics, but it's going to be 1 out of 5, just to be cool and relaxed about it.
Yeah.
But I think we became better surgeons in indicating what is suitable for repair, what was maybe kind of like a salvage indication, you kind of pushed it. So the things where I still struggle with are the ones with an ACL where you push the repair because it helps heal the ACL. And I tell those patients that there might be a chance that I have to go back in during their rehab at 6 months if the meniscus isn't healed. But I said there's advantages and disadvantages. The advantage is your ACL has been maturing with the meniscus with that stability.
Yeah.
That's the only one where I sometimes struggle still a little bit.
Are you seeing many re-tears after meniscus repair?
No, I don't see many, but I see some. You know, I see some, and you'll see ongoing patients with ongoing symptoms, medial symptoms, bit of discomfort.
Medial, right?
You know, yeah. And it's the medial meniscus. The medial meniscus is the challenge, and there's a big push, obviously, for meniscus repair. But you often see a peripheral lesion in the mid-body, but as it actually goes more posterior, then you're into a sort of more of a red-white zone. And you know, if you're trying to repair those, they don't do well. And actually, the majority do pretty good with a meniscectomy. It can be pretty forgiving. You think how many meniscectomies are done, and the number of patients that will have ongoing post-meniscectomy pain is pretty minimal. So I think you got to be careful. And you know, if you look at the Moon data, the biggest predictor of worse outcome after ACL reconstruction is a reoperation.
Yeah.
Right. And so you really want to try and cut that reoperation rate down if you can.
Yeah, on repairs on the medial side with the ACL, I think what is very important and what changed my practice is I do no longer indicate my repair during the surgery.
Right.
That means I look at the MRI. The MRI tells me 95% of the time repairable, yes or no. Because I think during the arthroscopy, you kind of overestimate the repair potential, especially in the back. That's the one on the medial side where you think, oh, that's a big lesion, but on the MRI, it's just white on white.
Yeah.
And that's where you do repair. If you just base yourself on the arthroscopy, and then it's going to fail.
If we, so we're talking about the back of the meniscus. Let's talk about root tears. With the root tears in the medial compartment, they can be really quite tight. You haven't got much space to get a device in, fire it. What are your tips of how to open up a tight medial joint?
Pretty low threshold pie crusting, and I do go on the femoral side, posterior fibers of the superficial MCL, and I just pie crust enough just to see. You know, I don't like this, you know, this whole thing popping open and you suddenly got this massive drive-through sign.
Yeah.
That makes me very, very nervous. I just do enough, just enough to see. But if I can do a meniscus repair without doing a pie crust, I'm definitely going to, you know, try and preserve that.
So logistically, for some people who may not be familiar with that, you're using a white needle, a green needle, a spinal needle?
18 gauge needle.
Yeah.
And you have the bevel positioned in such a manner it's more like a knife. So it's a very sharp blade.
Yeah.
And then you know,
Perforate the skin once.
Yeah, keep it in the skin.
Yeah.
And then go more to the posterior fibers.
Yeah.
Sometimes it's very, very easy to do it. You know, and I think it was a Korean paper that talked about this magic point that you can identify. We've tried to do that. It's very, very tough. So sometimes you hit it spot on and it just suddenly just opens and you think you're a rock star. Other times you're poking away and it's like, why is this thing not open?
Yeah.
It's a nightmare.
So you're going up on the femur.
Yep.
So there, you've got the leg in valgus on your hip, and you've got gentle sustained pressure. And then I know it sounds a bit anal, but what I'm asking is the actual technique. Are you going across? Are you going up and down? Are you kind of diamond shape?
I start going sort of in a anterior to posterior manner in a pie crust, and if it goes, perfect. If it doesn't, then I start to do little nicks.
Right. Okay. And are you
But you just got to be very, very careful because if
Yeah.
you soon start doing that, all of a sudden you can get the whole thing just to completely spring open.
And do you ever brace them? Have you ever had one that's gone with a big MCL? No. Okay.
Can I go back on the roots?
Yeah.
The thing is with the roots, I think we all struggle with the fact that you have your camera looking at the root and then your instrument and one blocks the other. So what I changed is I come from the opposite side. So medial root, scope on the medial side, and my aiming device from the lateral side. So I do a lateral tunnel.
Right. So you're drilling across on the lateral side of the tibia.
I drill across. That means that my pin is coming in my view,
Yeah.
and I'm away from the vascular elements.
Yeah.
Because I heard a terrible story recently from some colleague that you don't want to go there.
How does that? So personally, I fix mine on the medial side.
I fix them on the lateral side.
So when you're doing that, how are you fixing it on the tibia?
Post screw.
Okay. And so you're just clearing tibant out the way.
Tibialis anterior. I
Fine.
just go transmuscular.
Okay.
Yeah.
And you can get good view down to bone and then fix it there. Fine.
Yeah, the beauty about doing that is that if you go from the medial side and if you end up with a very shallow tunnel, if you're doing a transosseous pullout, I've had cases where actually I've put in tapes and the tape is cheese wired through the aperture of the medial root, and it just starts to come more into the plateau.
Yeah.
It's kind of disappointing, you know.
Yeah.
So you know, if you actually go from the lateral side, you're not going to run into those sorts of problems. So I think the key is that you've got lots and lots of ways of achieving the same thing.
Yeah.
And sometimes, depending on, you know, maybe doing ACL, PCL, you could be doing a whole host of different ligament reconstructions. You got to work around your tunnels.
Fair enough. Now, I want to talk about ramp lesions because that's been quite a bit of focus. The French claim that everyone has one, right? And my personal experience has been that it's less than that. I do a transnotch view every single arthroscopy I do. Admittedly, I don't then take a shaver and shave the shit out of the meniscocapsular junction and create one. But how common are they really? Is it something you see on a weekly basis, on a monthly basis?
This is going to be, weekly.
Okay. So common, and you're repairing them the way
Weekly
you
that
showed.
I see them on the MRI. It's not weekly that I
Yeah.
do them in the surgery, but I see them,
So we do often see them reported on MRI, query ramp lesion. You go in there, you pull the meniscus, you don't think, you go around the back, and you don't see it. So is that the one where we should then be taking a needle or a shaver to it, or do we accept that it is stable when we're pulling on it?
I think the biomechanical stability testing is also important. I think there's been maybe a little bit hype around the ramp and the potential of the ramp, but it is a lesion that if you can't treat it, you have to repair.
Yeah, I think
sure.
In many ways, I think if you can't see it through a trans-notch view, then I'm not sure it's important enough to repair.
Yeah.
So if you're really going to go looking for it, then yeah, you're probably going to find some more. But also, don't forget that it's not really an unstable meniscal lesion; it's an unstable tibiofemoral joint. So you're really looking to see whether or not there's increased anteromedial rotatory laxity as a result of that meniscotibial lesion.
And you're testing that on EUA?
Yeah.
And the data says you need to, or you're advised to do an LET or an anterolateral procedure in conjunction with your ACL. I think also that is very important. I think LET solved so many issues that we were having. Basically, ACL is, I think we have it. We nailed it.
Solved.
It's solved. What's the next problem on your list?
I've got a whole bunch of problems here. I can go all day. Let's just talk about LETs. So, Al, huge congratulations on the stability trial. I see you're still milking it now, 5 years on. But could you summarize it for people in the room? The outcome and recommendation of the stability trial.
Yeah, I guess. I mean, it's a large multi-center randomized clinical trial. It's the largest RCT and ACL reconstruction that's been done worldwide. It's over 600 patients under the age of 25, all with sort of identified as having risk factors of an increased risk of re-injury. All ACL reconstructions were done with a hamstring tendon autograft, controlled for graft size. So we really tried to get up to upwards of 8 millimeters. And we added an LET on a randomized basis, and basically we showed that we reduced the risk of graft failure by about 60%, and the risk of what we call clinical failure, which was persistent rotatory laxity, as well as graft failure, by 40%. So, I think what's come of that, it is the gift that keeps giving. I mean, we've published a lot of work from it. There's a huge amount of data, but it's really informed an awful lot of practice. I'm very proud of it. I'm very proud of the team. I mean, because there's a huge effort, a huge endeavor, and it's changed practice around the world. And it's enabled us. Issachos sponsored that for $200,000, and we've recently then got funding from both the NIH and CIHR, which is the Canadian North American sort of funding agencies. So we're doing stability too, and we managed to get $5.3 million. So that's the power of being able to do seed funding, small, a large study with small funding to be able to then leverage that and do a bigger trial. And it's going to inform a lot of what we're going to do in the future with regards to ACL reconstruction.
Look, as much as it pains me to say, it's been phenomenal. It's had a huge impact on knee surgery around the world. Which patients should everyone here be doing LETs on?
I mean, I think if you're seeing a lot of young patients, certainly under the age of 25, young athletic patients, and you're doing a soft tissue graft, in my opinion, you should be doing an LET on them all. And you got to remember is that 90% still did well. So we're not saying the hamstring tendon is a terrible graft, right? But we just know that that patient population, there's a higher risk of re-injury. And I talked yesterday about the downside of LET. I mean, there's not that many downsides really, in the short term for sure. And so what would you rather do? You don't want that young patient, you don't want that young athlete to have a failure. And so if you can do something which is relatively low morbidity, low cost, and has a potential of having a dramatic impact on their outcome, why would you not do it?
Fair. And Peter, how are you fixing yours?
2 fixations, staple, routine, and then there is
Where are you putting your staple, please?
distal femur, lateral side, posterior side of the femur.
And where in relation to the epicondyle?
Proximal.
Okay.
Yeah. So the monoloop, classic LET, modified Lemaire, whatever you can call it. And then there's one thing that I think we struggle with is some patients lose quad function after ACL. And it takes them time. And especially in my population, that's more females than males. And I do blame the fact that we go below subvastus approach. And so in those patients where I think there might be up for some period of loss of quad, I'll do a fixation a little bit more distal, not lifting off the lateral vastus with a suture, and just a Kocher-Arnold approach, basically.
Okay.
And that's a bit of a soft skill in terms of judging a patient that you think. So tell us a little bit about what does that patient look like? What are the key signs that you're thinking that patient's not going to be able to activate their quad?
So first of all, I do surgery, tourniquet, and then my patient would be more likely a female patient with not that big bulk of muscle mass. And there's no other parameter. I just look for the patient. If she has some hyperextension, for example, I might be a little bit wary of her getting back at speed with the quad. I do believe, and this is where we had a number of discussions or, opinions, I do believe that part of the LET success is not just the lateral procedure with the lateral staple, but also weakening the quad for a number of weeks to months, allowing your ACL to heal in a non-aggressive environment.
That's fair. And Peter, are you doing many quad tendons?
Growing number with bone block.
Yeah, right. And now your quad tendons are all the rage in North America. Go to every meeting you hear about. You're doing quite a lot of quad tendons now?
Doing quads based mainly because of puff stability too, so we're randomizing a lot. But I would still, if a patient doesn't go into that trial and they ask me what I would then do for them, I'm doing more BTBs just purely because I've been doing that for a longer period of time. It's got a longer track record, and I still think it's a great option.
So your number one go-to ACL graft is BTB?
Correct.
Number two, quads?
Quad. In that young patient population. In the older patient population, it'd be a hamstring.
Thank you. Listen, we're out of time there. Just say Al actually recorded an Orthohub podcast with us in the studio, and it was actually, pains me to say, it was fantastic. Don't tell Andy Williams, but I think it's the best one yet. So that's going to be out next month, so keep an eye out for that. There's some bad behavior. And listen, I just want to thank you to Conmed for sponsoring this session. I'm being ushered off the stage, but thank you very much.